Okay, part 2 of DNA viruses. We are going to continue on and talk a little bit more in depth about the first 4 of the human herpes viruses. And I apologize, there's a little hum in the background here because my neighbor is taking out a bunch of trees today. And this was the quietest room that I could get to, but I know I can still hear those machines going a little bit. All right, so HHV1 is often referred to kind of colloquially as above the waist herpes. Okay, it's very common. It's estimated that about half of us have HHV1 latent in our bodies. It usually manifests as gingivo-stomatitis, otherwise known as cold sores or fever blisters. All right, so these are fairly painful kind of blisters that one gets inside their mouth or on the lips, a little bit on the skin around the lips. That is transmitted between people by close contact. So typically sharing drinking glasses or eating utensils, kissing, for example. And those sores usually last about a week, okay, 7 to 10 days. There's usually a little prodromal period before they erupt, a little tingling or itching at that site. HHV1 can manifest in other sites of the body besides the mouth. It can manifest in the fingers or the eye, for example. These actually could be for HHV2, potentially as well, though. All right, so when herpes manifests in the finger region, we call that Whitlow's disease. Okay, so this is one of the many reasons here that dental hygienists and healthcare workers wear gloves, because the virus can easily enter in breaks in the skin around the cuticle or the fingertip there, and then manifest themselves. Especially if somebody has some Whitlow here, they itch their eye, it can very easily, the infection be transmitted to the eyes. And then we call it herpetic keratosis or keratitis. Okay, so that causes some sensitivity to the light, kind of almost kind of a grainy, kind of a sandy feeling, apparently. It can also manifest as permanent vision damage, so this is getting a little bit more serious. Very rarely, HHV1 or 2 can manifest in the central nervous system, the brain, or the spine. And that's going to be almost only in immunodeficient hosts. That does cause substantial mortality, but thankfully that's quite rare. With all these infections, of course, this can be a primary infection or it can be manifested latently as well. All right, so I will spare you the graphic pictures of HHV2, but this most commonly causes lesions on the genitalia, targets the mucosal membrane in the urogenital tract. Most commonly, this is acquired in the teenage or early adult years as a result of sexual activity. It's actually one of the more common sexually transmitted diseases. We talked about chlamydia was the most common, and then we think gonorrhea is second. But it's estimated that 1 out of every 6 adults is infected with HHV2. And of course, there's no cure to herpes, so that's a little bit more serious, sobering number there. Let's see. It can be spread most commonly if there's an active lesion, but not necessarily. So can be spread even if there are no active lesions. Some people have outbreaks as often as 2 to 3 weeks, but more commonly, maybe 2 to 3 times a year. Okay. And it manifests as, these lesions are they're gonna be causing itching, some discharge, sometimes fever as well. And I should remind you that HHV2 actually can cause lesions around the mouth, but that's thought to be due to oral sexual practices. Okay, neonatal herpes is much more serious. It's usually caused by HHV2 because babies contract during birth. So if the mother is having an outbreak, then they will always deliver the baby by C-section, just to minimize the risk of passing that on. But it causes an infection that often resembles gonorrhea in newborn, so commonly would infect the eyes. It really depends on how fast the baby's immune system can respond as to how serious it is, but this can be life-threatening. Okay, and when the mother has genital herpes, it also increases the chance of miscarriage and preterm delivery. All right, remember we mentioned in the last video how all the herpes viridae go latent as episomes. Remember those little pieces of DNA, they don't integrate into our chromosomes, but they're almost like plasmid-like. They get replicated every time our chromosomes get replicated. So focusing on HHV1 and HHV2, HHV1 is commonly going to go latent in the trigeminal nerve ganglion. So this is cranial nerve number 5. There are 3 branches there, and so typically somebody with some kind of cold sore is probably typically going to travel up the maxillary or mandibular branch and again go latent in that trigeminal nerve. That's ocular herpes would travel up the ophthalmic branch of that trigeminal nerve ganglion, and then so it would replicate there, and every now and then get reactivated and travel back down one of those branches. Whitlow will typically go latent in the brachial ganglia, and genital herpes, again more commonly HHV2, typically goes latent in the sacral ganglia. Okay, so again, replication cycles would occur in that latent site and then reactivate from time to time as blisters. So what causes reactivation? Typically it's going to be some kind of stress, and some things you wouldn't necessarily think about as being stressful, like sunlight, right? So the patient's out in the sun all day, maybe gets a little sunburn, okay, that can cause an outbreak. Menstruation, of course, immunosuppression, that one's a little bit more obvious. It could be some immunosuppressive drug, or it could be disease, HIV, AIDS. Chemotherapy, of course, is usually immunosuppressive. and of course fever. So you have some other kind of infection, a cold or whatever. That's a common time that a cold sore would break out. The good news is that usually the infection is less severe when it reactivates. So over time, the body produces some antibodies, and the symptoms typically are a little milder over time. All right, what kind of treatment do we have? And then I'll just mention vaccine briefly here. We don't have any drugs that is going to cure herpes, but we do have medication that can lessen the severity and frequency of outbreaks. Acyclovir is not only used for herpes, but it's used for other viral infections as well. It's actually I forgot to fix this, it's a nucleoside analog. So little genetics review, remember a nucleotide is the base and as well as the sugar, say deoxyribose, as well as the phosphate. The nucleoside is just the base and the sugar. So the way acyclovir works, I believe it's a guanine analog. So acyclovir resembles guanosine, which is guanine along with basically the deoxyribose. So it's deoxyguanosine, it's the guanine nucleoside. Acyclovir has the guanine, and of course the ribose is not quite the same there. But viral polymerases are much less discriminate than what our polymerases are, either DNA polymerase or RNA polymerase. Our polymerases are pretty particular, and they wouldn't incorporate something like this into our DNA or RNA. But viral polymerases, again, they just kind of throw these in a little bit more indiscriminately. And of course, with acyclovir here, there's no 3' hydroxyl group, okay, here. So once acyclovir is incorporated into, say, the DNA, then the DNA that strand can't be replicated anymore. So basically it stops replication of the virus, or slows it down for sure. Okay, so that's pretty much our best bet to control outbreaks. Again, it also reduces the chances of passing the virus on to sexual partners. Really, other than that, just some over-the-counter menthol or camphor to kind of reduce the irritation of cold sores. There is no approved vaccine for herpes virus, but there are at least several vaccines in clinical stages for genital herpes. That's not preventative, but it's therapeutic. So in other words, when somebody contracts herpes, then they take the vaccine instead of the other way around. I was just reading, there's one that's showing a lot of promise that reduces the number of outbreaks that a patient has and decreases the viral shedding, so decreases the chance that they're going to pass it on to somebody else. Again, nothing approved yet, but there's some promising things in the pipeline. All right, HHV3. Maybe this would make some good dinner time conversation, much more so than HHV1 or 2. If you're home or when you go home over the holidays, ask your parents if they've had chickenpox, because most people from our generation have. For me, I had it I just have terrible memories of having that when I was 8. So when that vaccine came out in 1995, I was the first one to sign up my kids to get that. Okay, so it's also known as varicella zoster virus. And this word zoster is Latin, I believe, and French for belt. So that is not immediately obvious how that pertains to chickenpox, but we'll get to that in a minute. Like our other herpes virus, this is a human only, something we pass around between humans. Okay, so I'll make note of that. Not zoonotic, even though chicken pox, we don't get it from chickens. I think it reminded somebody, the rash that comes out in chicken pox reminded somebody of a plucked chicken. I think that's where the name came from. How do we transmit it? Have to be in close contact, respiratory droplets. So near somebody that's coughing, sneezing. And the interesting thing here that it is transmissible, or we'll say contagious, during the incubation period. And of course, are you having signs and symptoms in the incubation period? No, nothing mild even. So usually it starts being contagious a couple of days before the rash breaks out. All right, so again, people are going about their daily activities, and that's one of the reasons that chickenpox is so contagious. And people don't know they're about to get it. Okay, and it only stops being contagious when those sores scab over. All right, so symptoms, oops, I got that down here. Rash starts out on the trunk and moves out from there over your whole body. I even had a rash inside my mouth and in my throat. So these little fluid-filled vesicles, they're very itchy, especially once it starts to scab over. Okay. Other things common, fever, malaise, things that are very common in any viral infection, loss of appetite. Okay. Now, usually this infection clears up on its own. So a good week to 10 days, and then the infection is cleared, no after effects generally, and we have good memory, immunological memory to it. So typically once you get it, you don't get it again. So that when the vaccine came out, there was kind of a big hoo-ha about, well, why do we need to vaccinate against an infection that really isn't that serious? So I'd like to make the case that there are some very good reasons that we should vaccinate against chickenpox. And we'll start with the weakest argument and then head down to, I guess, the more compelling arguments. All right, so first of all, there is a chance of getting some kind of secondary infection. So this means this is an infection that happens only because you had chickenpox in the first place. All right, so like I said, when those lesions scab over, they're really itchy. So it's pretty easy to scratch off a scab before it's ready to come off, and then you have a little open sore there. So it's not uncommon to get some kind of staphylococcal skin infection as a result of scratching off those scab. Makes an easy portal of entry for the staphylococcus. And that's pretty common. Less commonly, some kind of secondary infection like pneumonia or encephalitis. Encephalitis is inflammation of the brain. Well, those are pretty rare complications. An even stronger reason to vaccinate is because, remember, this is an infection that goes latent. Okay, it's integrated as episomes in the nerve ganglion. So when it reactivates, so HHV3 reactivates as an infection known as shingles. All right, so ask your parents if they've had chickenpox. Maybe next time you see your grandparents, ask them if they've had shingles or anybody they know has had shingles. This often manifests as a very painful rash, not an itchy rash, a painful rash. Often manifests as kind of in a belt-like pattern, so it's kind of hard to tell. This is somebody's waist, sort of a belt on one side or the other, because typically it will reactivate in one nerve on one side of the body or on a nerve on the other side. Here in this person, again, it's very striking, the sidedness of the rash. It's reactivated in one, I don't know if this was maybe the ophthalmic branch, perhaps. Okay, so extremely painful rash. Lasts usually a couple weeks. Again, maybe a little acyclovir to kind of lessen the pain of that. About 30% of people that have had chickenpox will get shingles. Okay, so, whoops, didn't spell that very good, shingles. All right, so that's a pretty good reason, if you've had chickenpox. I know once I'm old enough to get the vaccine, I'm going to be first in line, because this is something that I don't want to mess around with. And about 10% of people with shingles, that pain just goes on and on and on for months. We call that post-herpetic neuralgia. Okay, so basically they have pain caused by nerve damage, and again, it just can continue for months. It can be very difficult to endure. And in addition, an adult with shingles, if they are around, say, babies that have not been vaccinated or have not had chickenpox, they can give chickenpox to a child or anybody that hasn't ever had chickenpox. So in your book, there's a picture of a grandpa holding his newborn twins, and he has shingles. So, you never want to give any kind of infection to babies. So it's potentially kind of a dangerous thing. I had a student ask me a few years ago, she said, well, I never had chickenpox. I've never been vaccinated, and I work in a nursing home. Do you think maybe I should get vaccinated? And I said, yes, you should do that today. Because if you contract chickenpox when you're, say, a teenager or a young adult, it's a much more serious infection. You have a much higher chances of complications if you contract chickenpox as, again, a teen or adult. Okay, one of my colleagues, he got chickenpox when he was a teenager, and his lesions, he didn't just have the little rash like this. He had great big lesions that almost kind of grew together when he had chickenpox as a teen, and he was sick for much longer than somebody normally would be. And again, if you get it as a teenager or adult, you're much more likely to have these serious complications like pneumonia or encephalitis as adult. So that's a really strong reason to vaccinate. Again, number one, you won't get shingles. If you've never had chickenpox, you shouldn't ever get shingles, right? And again, and you don't have to worry about getting it as an adult when you have a lot more inflammation, a lot more, potential tissue damage. All right, so hopefully I've convinced you that it's a good idea to not only yourself maybe get vaccinated if you haven't been, or vaccinate your kids someday. That vaccine that we have for kids is called Varivax, and that's given to kids usually around 18 months and again at 4 to 5 years. Has very, very good protection if someone does end up getting chickenpox even after they've been vaccinated. It's usually very, very mild infection. And today we have a vaccine against shingles called Shingrix that came out fairly recently in 2017. It's a much better vaccine against shingles. It's actually a killed or inactivated vaccine, where Varivax is actually attenuated. It's a weakened strain. Where Zostavax, that the old vaccine used to reduce your chances of, if you had chickenpox, as reactivating as shingles by about 50%. The Shingrix is now better than 90% effective. Okay, so you get that in 2 doses. I think they have to be maybe a month or 2 apart, and it's recommended for everybody. It's 50 years old or older, and it lasts about 4 years, we think. Okay. Unfortunately, it does have some side effects. Oftentimes, people maybe have a little fever the next day, a little headache, fatigue, maybe for about a day. But that's nothing compared with getting shingles. So encourage your parents to get this vaccine, again, maybe even over the holidays. Okay. Again, only treatment we have for shingles is the acyclovir. Helps with the itching of chickenpox or the pain of shingles. And I would add, if your parents or grandparents say, "Oh, I've had shingles already," you can get it again. Usually somebody will only get shingles maybe 2 or 3 times, not like over and over again, like, an active, like, cold sores or something. But you can get it again. I've talked to high school students that have had shingles. I've had friends in their 40s that had shingles, but the chances of getting shingles increases as we age. So again, that's why it's especially recommended for adults over 50. And lastly, I want to touch briefly on HHV4. It's also called Epstein-Barr virus for the people that first isolated it. There's several manifestations of HHV4 depending on the host's immunological status and age. So we'll talk about a few of those. This is one of those viruses that can be oncogenic. All right, so it can cause something called Burkitt's lymphoma. This is a cancer of the jaw. Also usually manifests in some abdominal tumors as well. It was the first virus that was shown to be able to cause cancer. And it goes latent in B cells. Okay, HHV4 does. Most commonly, we see this in boys. And especially in African boys. In the U.S., there's only about 300 cases of Burkitt's lymphoma, again, usually in boys. Not sure why it seems to favor boys and not girls. But again, it's much more common in Africa, and we're not really sure the link there. It was hypothesized that African boys' immune systems are often suppressed perhaps by malaria. There's been some questions recently as to whether this link is real, and we don't really have another hypothesis to explain why that is. Okay, it's a very fast growing cancer, but it's also very treatable. Okay, it responds really well to chemotherapy. So at least there's that good news. Probably the infection that you are more common with that HHV4 causes is mononucleosis. Okay, this is also called the kissing disease because it's transmitted by saliva. Okay, so kissing, sharing drinking glasses, sharing water bottles. So in your gym or if you're on a team, have your own water bottle for sure. Most common in teenagers and young adults. And the symptoms there, extremely sore throat, feels kind of swelled up, enlarged spleen. So have to be really careful about returning to contact sports after one has had mono. So the spleen is at risk of rupturing because it's enlarged. Enlarged spleen and liver, I'll add. Extreme fatigue, which can last quite a long time. So why does it make patients so tired? Remember, this is affecting the B cells. It's kind of been described as sort of a civil war between T cells fighting infected B cells that cause all those symptoms. Typically, it goes latent in the B cells, and then typically somebody doesn't get mono again. So if they've had it once, they're not likely to get it again. So why is it teenagers that get mono? Well, we think, again, just to wrap up here, that the range of infections caused by HHV4 has something to do with the state of the patient's cellular immunity. All right, so someone with vigorous cellular immunity, they're in their prime, they're a teenager or young adult, typically that's going to manifest as mono. So kind of as a result of that inflammation that our immune system is able to generate. Somebody with more, say, normal immunity, maybe a child, if they were infected with HHV4, probably wouldn't show any symptoms. It's very rare for a child to have mono. Okay, and it's been hypothesized that in developing countries, almost everybody as children are exposed, and so you rarely see mono, again, in developing countries. If the immune response is more poor, then we think probably that predisposes kids when they're exposed to Burkitt's lymphoma. This nasopharyngeal cancer is a little bit more prevalent in China for some reason. It's just been hypothesized that a couple other diseases here may have some HHV4 link, but it's not really been proved. If one's immunological status is very, very poor, in fact, almost non-existent, this would be somebody with HIV, AIDS that's not been treated, probably, then they are more likely to see this precancerous change in their mucous membrane of the tongue. That's known as oral hairy leukoplakia. And again, that's just typically seen in AIDS patients that have a T cell deficiency. All right, so next lecture, we will be moving on to some RNA viruses.